last year, 3 years. So I am thrilled to invite Sarah Farrell to now take the stage, and she will be talking about progress within pathology, a spectrum model of eating disorder recovery. And if you are a student here, just don't forget to sign the form over here if you were here, if you need to get credit for this before you leave, okay?
And there are some seats down here if anybody needs. Oh, thank you so much all for being here. I feel a kaleidoscope of feelings. Once again, my name is Sarah Farrell, and I'm a graduate student here in the Mindfulness-based Transpersonal Counseling Program. I've also been working in the eating disorder field for 7 years in various capacities as a mental health advocate, educator, as a meal support coach, even as a recovery yoga teacher. This afternoon, I'll give a woefully brief introduction to the world of eating disorders, and then I'll present a case study that literally illustrates the non-linear nature of recovering from an eating disorder. From there, we'll talk about how this might inform our conception of recovery and of best practice. Eating disorders are complex biopsychosocial illnesses with multifactorial etiologies. In other words, there's no single culprit that causes an eating disorder, and they are notoriously challenging to treat. We're talking about diagnoses such as anorexia nervosa, both the restricting type and the binge purge type, bulimia nervosa, binge eating disorder, and OSFED, other specified feeding and eating disorder. The best way to think about OSFED is as a catch-all diagnosis for eating disorders that are clinically significant but fail to satisfy all of the criteria for one of the established eating disorders. So I will be using the abbreviated OSFED. For the sake of time, your handouts include specific information on each of these on pages 2 and 3. You'll note that I provided you with information on all of the feeding and eating disorders that are included in the current Diagnostic and Statistical Manual of Mental Disorders, although my presentation today pertains to just these few here. If you read through pages 2 and 3, you'll see symptoms such as an intense fear of gaining weight, a self-evaluation that is unduly influenced by shape or weight, a disturbance in the way one's body is experienced, also known as body dysmorphia. You may see food restricting. You may see binging. You may see compensatory behaviors such as purging, abusing laxatives, or over-exercise. And you'll also see scattered throughout distress, guilt, or shame about eating behavior. Let's talk briefly about prevalence. In the United States alone, at least 30 million people are currently suffering from an eating disorder. That's people of all ages, genders, races, and ethnic groups. Eating disorders do not discriminate. If you take a look at the current US population, that's about 9%. 1 in every 11 people. And the truth is, due to stigma, misconceptions, and lack of access to care, not to mention the institutionalized racism, classism, and other isms of the academic and research fields, this figure is likely quite low. These are also serious conditions. All eating disorders have an elevated mortality risk. They can be deadly. What you're looking at here is the increase in mortality associated with eating disorders. Anorexia in particular, get this, has been associated with the highest rate of mortality among all psychiatric illnesses. This percentage here, indicates that a person with an anorexia diagnosis is over 5 times more likely to pass away than a similar person without the diagnosis. In the cases of anorexia and bulimia, 1 in 5 deaths are the result of suicide. As for their resistance to treatment, I think I flipped too early. Sure did. One longitudinal study by Anne Van Hol and colleagues found that after 15 years, only 25% of those with bulimia nervosa met the most basic recovery criteria. For that same period of time, 15 years, for a population with anorexia nervosa, I'm afraid that recovery rate was only 16%. There's a dearth of longitudinal information on binge eating disorder, but one study found that only about half met recovery criteria 3 years after treatment. And finally, as it is sort of a newer constellation, there's really a lack of longitudinal research on OSFED, formerly known as EDNOS. Relapse is common. Depending on how it's defined, relapse rates range from 9% all the way to 42%. And even in those cases of a successful recovery from an eating disorder, the recovery process can be a long, hard, relentless slog. Don't worry, y'all, we're about to pick it back up. In order to illustrate this long slog, I'd like to bring in a case study. It's a case that I know quite intimately because it's my own story. And here, just by way of content warning, I am going to acknowledge specific eating disorder behaviors, so I want you all to have my full permission, not that you need anybody's permission but your own, to self-regulate however you need. And if that means you need to take a break, that's fine. You see, I myself suffered from an eating disorder beginning at about age 11 all the way until age 24. Briefly, it manifested as anorexia. And then for some time, it shifted into a sort of OSFED situation. But eventually, I developed and struggled the longest with bulimia nervosa. And the truth is, I was so high functioning. And extreme dieting is so normalized in our culture that, to be honest, for the most part, I skated right under the radar of those who loved me, and I didn't receive formal treatment. I was supposed to click that some time ago. But just look at how high functioning she looks. By the time I was in college, I was suffering greatly, both from bulimia as well as clinical depression with suicidal features. At 20 years old, I decided to try individual outpatient psychotherapy for the very first time in my life. And it was around that time that I also decided I wanted recovery. And I was fully committed, in theory. What I didn't know then was what a long road I had ahead. You see, eating disorders are, to say the least, very difficult to just stop. If you've ever heard somebody say, just eat a sandwich, slap them on the wrist for me, will you? They're complex coping mechanisms, and something like a binge purge episode can feel as though you are in an altered state and someone else is in control. So even after I decided I wanted recovery, I had a lot of bad days. On those days when I did not induce vomiting, those days I considered my good days. And I don't remember how this started, but I always had a calendar hanging on my bedroom wall. You can see it in this picture. See it right there? I eventually framed it, and you'll see why. Somehow I got into the habit of circling a little heart around the days that I did not throw up my food. So if I got through the day without purging, I draw a little heart. It gave me hope, and it felt like a tangible victory, something I could point to. This went on for years. Years. 2005, 2006, 2007. And at some point in 2007, I was taking down my calendar from off the wall to replace it with this one. That's the actual 2008 calendar. And I added the old calendar to this pile of past calendars. And suddenly, it hit me. Oh my God, I have data. I was an actress at the time, but my dad's an engineer, so maybe that had something to do with it. And so at 23 years of age, 6 years into my battle with bulimia, and 12 years after the onset of my eating disorder, I sat down with a piece of graph paper and a pencil, and I started to graph out my own symptomology. On the x-axis, I tracked weeks. On the y-axis, I tracked number of symptomatic days in a week. So in other words, if I had purged my food at least once on any given day, that was a symptomatic day. So the highest point possible would be a 7, right? Indicating that on that week, I had thrown up at least once on every single day of that week. Capiche? Okay. I poured myself into this project, and the payoff was huge. For instance, by looking back through my planner to see what was going on in my life at the time, I was able to see how symptoms would spike at, around, or before stressful events. So you'll see here that I was asymptomatic for 3 weeks in, looks like July of 2005. Well, I looked in my calendar, or in my planner rather, and it turns out that during those 3 weeks, I was at home in the house where I grew up with my parents in SoCal. I was in an environment where I felt loved and supported and cared for. And so I was able to refrain from my behaviors. But check this out. As soon as I returned to San Francisco, where I had a new school semester starting, rehearsals for an opera starting, and this circle here was a shoot day for a film that I was in, about which I had a lot of body anxiety. And what do you know? Look at the symptoms pop right back up. But believe it or not, this is not the number one reason this graph was of value to me. No. The number one reason my recovery graph was of value to me was because it allowed me to step back and to take in a wider perspective and to see with my own eyes how painfully slow my improvements were. But they were improving. So, here you have it. Oh, it's such a pity you can't see it. Such a pity. You know, what you would be seeing here is the entire recovery graph spanning 4 years. You know, it would have been really great if I had, like, I don't know, made a life-size version for you guys that was like color coordinated so you could see it. So, I'll pull it up here, and feel free to stand up if you need. Yeah, that's okay. What you are looking at is the last 4 years of my purging symptoms. Over time, it's clear that symptoms are diminishing. But this is a rocky road. Just look at all those ups and downs and ups and downs. What's most interesting to me is how this chunk of time right here looks pretty darn similar to this chunk of time right here. If I had based the likelihood of my recovery on this moment, do you see here, this moment in 2006? I mean, what do you think would have happened? I think it's likely I would have given up hope. I would have been like, I'm never gonna get better, here I am at 6 again, you know, I'm doomed. That's because back then I did not have an understanding that recovery from eating disorders is a nonlinear process. In fact, the literature confirms this. In a brilliant paper by McGilly and Sabluski, that I will refer to more than once in this talk, they concede that improvements from an eating disorder, quote, do not occur in a linear systemic fashion. And remember, this graph only tracks one symptom, right? Which is whether or not I induced vomiting on any given day. But if we could track other subtler symptoms, such as negative self-talk or discomfort with fullness, this graph would continue on for some time in a similar fashion. So the lessons from this graph inform how I talk to my clients about recovery. All too often, clients express deep shame and hopelessness about episodes of relapse in their journey, about messing up. You know what I tell them? I tell them, your eating disorder wants you to think that recovering is black and white. It wants you to believe that you can be perfect at recovery. That way, when you mess up, you're more likely to give up and then the eating disorder wins. If I can help clients to see that they're not back at the beginning, but instead, right here at one of these flare-ups, then they're more likely to retain hope and motivation for full recovery. Research points to why this might be effective. Perfectionism has long been noted in eating disorder populations. And research out of the University of Western Australia has found that perfectionism remains elevated even after recovery. Just ask my husband. Or anybody in this room who's known me for more than 10 minutes. But more specifically, those with eating disorders are more likely to see the world in stark black and white. Black and white thinking, also known as all or nothing thinking, dichotomous thinking, or absolutistic thinking, is a cognitive process that perceives things in one of two opposite categories, never in between. So it's either, you're a saint or you're a sinner. It's totally perfect or totally shit. This style of thinking is a fundamental problem in eating disorders. Research from Lethbridge shows that it's higher in individuals with both clinical and subclinical disordered eating. And in anorexia and bulimia, get this, black and white thinking explains variance in psychopathology beyond perfectionism and beyond over-evaluation of shape or weight. Black and white thinking. Ramachadi compared people in larger bodies with and without binge eating disorder. And dichotomous reasoning was found to be more present in folks with the eating disorder. So it makes sense to me that a person with an eating disorder might view their own recovery in black and white terms, right? I'm either perfect at recovery or I'm doomed to live with this eating disorder forever. And I believe we can do our clients a great service by ushering them into these shades of gray and celebrating the imperfection of their journey. Did I try to find a gray outfit for today? I did. It's not my best color. So how might this inform our view of recovery? Well, I want to start by asking, how do we define eating disorder recovery? Great question, right? Are you ready for the answer? The truth is, as so many in this room know, our field has no consensus definition. Certainly in quantitative research, recovery is most commonly defined by the cessation of behavioral symptoms, or more simply, when a person no longer meets the criteria for a DSM diagnosis. So like my graph, right? Symptoms are gone, must be recovered. But folks who work in the industry believe that this focus, many of them I should say, believe that this focus on the physical parameters of recovery is insufficient, considering these are complex biopsychosocial illnesses. So Carolyn Costin is a brilliant, well-respected eating disorder professional, as well as the founder of a national treatment organization, and she's a bit of a rock star in our field. This is how she conceptualizes the totality of recovery in what I think is one of the fullest, most comprehensive definitions. So number one, you don't demonstrate clinically diagnostic behavior, and number two, you're no longer using your eating disorder behaviors to cope with life. Pretty good so far, right? All right, now pay attention to these next three. I do have a question for you. Number three, you accept your body and shape as it is. Number four, you do not have a self-destructive relationship with food or exercise. And finally, numbers? Who cares? So just as an aside, I have a question for those of you in the audience who have never had an eating disorder. Just to contemplate, you don't have to answer out loud. Do you meet all of these recovery criteria? No. I only ask in order to illustrate that these criteria, while wonderful, may represent a bit of a high bar. If I am prone to black and white thinking, and this represents recovery, I may have doubts as to whether or not I will ever be able to attain it. What's interesting is that if you ask patients how they see recovery, they're more likely to describe it, quote, not as an endpoint, but as a multi-dimensional process in which they are simultaneously and variously making progress and experiencing setbacks. And so, oh, there was that quote. You can read it again, it's so good. And so, I get carried away, you know? I have come to envision eating disorder recovery in my own way. It's very bold. I'm quite nervous. I propose utilizing a spectrum in order to conceptualize eating disorder recovery. This actually reflects a larger trend in the mental health field, one in which mental illness is increasingly placed on a spectrum rather than in discrete etiological categories. Philippe Billedieu published this piece entitled Spectrum Abnormality, the Current Crossroads in Mental Health. And the point he makes is that as a field, we are organically moving toward envisioning abnormality on a spectrum, no matter the diagnosis. So here's how I see it. It's not perfect, but it gives you a good idea. We start with a spectrum, pathology on one end and recovery on the other, with many, many, many shades of gray in between. Toward pathology, we might see something like compromised physical health, the need for hospitalization and weight stabilization. And you'll find this on, pages 4 and 5. Loss of menses. You might also find at this point that the eating disorder manifests as ego-syntonic. In other words, as consistent with self-image and in harmony with the needs of the ego. There might be a disinterest in changing. At some point along the spectrum, you might find that the eating disorder becomes ego-dystonic, dissonant with the needs and goals of the ego. There might be increased motivation to change at this point. Later, there might be a diminishing of clinically relevant symptoms, culminating in a time when the individual no longer meets the DSM criteria for a diagnosis. But thereafter might come the less overt markers of the eating disorder, such as psychiatric distress, lingering preoccupations with food, those cognitive distortions, such as black and white thinking, and what are referred to by folks in the field as eating rituals, which are habits that seem abnormal, such as cutting your food into teeny bites or like dismantling a sandwich to eat it one ingredient at a time. Somewhere along the spectrum, you might find deviations from omnivory, such as veganism or vegetarianism, which, after all, by their nature are somewhat restrictive, right? And closer to the ideal of recovery, a person might be making progress in dimensions of underlying trauma, in intra-psychic and interpersonal conflicts, tolerating emotional stressors and environmental stressors. Other dimensions might include distress tolerance, practicing agency, setting boundaries, social functioning, and developing self-care, self-esteem, and life purpose. I do want to give a shout out to McGilly and Zablewski, the aforementioned, because some of these latter aspects of recovery were taken from a brilliant paper of theirs in which they refer to them as necessary ingredients in recovery. Finally, one could argue that full recovery cannot be achieved until we heal the disordered norms of our communities and our culture. So I've placed these markers here in only a general order, and I submit, I want to make sure I get this next part right. Yeah, because I want you to know that these are sort of randomly placed, and I submit that each individual's recovery spectrum is going to look a little bit different, with different dimensions of recovery, and those dimensions may even be placed in different positions along the pathology recovery spectrum. Here's a take-home point. When we envision recovery in this way, we allow ourselves as clinicians to really celebrate a client's progress, even if they are still hanging out in the midst of pathology. I also believe my model makes room for those who believe that there is such a thing as full recovery, as well as those who see themselves as perpetually recovering or in recovery. I envision a threshold of recovery beyond which some will have the genuine experience of being truly, completely done, recovered, and others may see themselves as sort of always having to stay vigilant. I believe this model can accommodate both. Likewise, I see a threshold that indicates when folks are in need of immediate life-saving intervention. So what's in between these two thresholds? I've been calling it the zone of potentially chronic, non-life-threatening deviations from normalcy. It's an easy name. You'll wake up at 3 a.m. thinking of it. Remember those devastatingly low rates of recovery from the beginning of the presentation? This is where many of those folks live. And I think it begs the question, for those individuals who may otherwise live the remainder of their lives with a chronic and enduring eating disorder or a shadow of an eating disorder, can we utilize a harm reduction model in order to usher them as far along their own recovery spectrum as possible? This all calls to mind an approach utilized in severe and persistent cases of schizophrenia and psychosis. It's called the recovery model. And it's a social movement that focuses on building a meaningful life as defined by the person themselves, whether or not there are ongoing or recurring problems or symptoms. There's a focus on health, strength, hope, and agency as opposed to pathology and disability. There's an emphasis on social support. And finally, an emphasis on constructing an identity separate from the illness or the disability. In populations with schizophrenia and psychosis, this model is doing quite well. What would it look like to apply a similar model to an eating disorder population. It turns out there is a program in Vancouver, British Columbia that is doing just that. It's called the Community Outreach Partnership Program, and instead of focusing on reducing eating disorder symptoms, they focus on increasing quality of life, reducing distress, and increasing hope for the future. Kim Williams and colleagues followed 31 participants from this program, and their results are stunning to me. After an average of 29 months in this program, these patients showed significant improvements in global distress scores, in hopelessness, and in BMI and eating disorder symptoms. Additionally, they reported increased importance of relationships and decreased importance of shape and weight. In other words, without trying to improve symptoms, simply by supporting these folks exactly where they were, these clients got better. We're nearing the end of the presentation here, and I'd like to just briefly touch on a couple of the potentially controversial implications of really embracing recovery as a multidimensional spectrum. Each of these could be their own capstone. This was the best I could do. For instance, treatment centers typically prohibit or discourage vegetarianism and veganism, and understandably so, because these dietary styles, as I mentioned, are by their very nature restrictive, and research does show that they can be used to disguise eating pathology. However, the spectrum model of recovery might celebrate a client's choice to go vegan if that choice allowed them to weight restore, to experiment with new foods, or to invest in an identity based on ethical altruism instead of being a broken person. Another area which might be rocked by this spectrum model of recovery is that of the recovered clinician. Research by Costin and DeLazer indicates that at least half of all eating disorder clinicians are themselves recovered. And this is a population that endures much more scrutiny than, say, a therapist who once suffered from depression or anxiety or PTSD or even addiction. A recovery framework which views recovery in black and white terms has the potential to promote a culture of silence and shame among clinicians who are truly recovered but still human. A framework that acknowledges and celebrates the complex spectrum of recovery will allow truly recovered clinicians to show up as their full selves, to be more realistic about potential countertransferences that are likely to happen, and to seek extra support when they need it. I, for one, feel very hopeful about inviting complex nuance into my understanding of eating disorder recovery. As I illustrated this afternoon, I know firsthand what a long and discouraging road it can be to recover from an eating disorder. I also know that it's possible. And I know from my clients that conceptualizing recovery as an all or nothing deal can lead to hopelessness, self-pathologizing, and decreased motivation. I believe that my clients benefit from being celebrated in the messy imperfection of their personal recovery journey. And far from enabling their psychopathology, I believe it supports them in moving forward toward their own inherent health. Please see your handouts for a life-size version of my references. And I want to end by saying thank you to my classmates, to my teachers. Okay, now it's coming. To my colleagues, and to my fellow interns from Papal House, to all of the eating disorder researchers and clinicians who have come before me, And finally, to my family, my parents, who I love so much, and my babe for life, Andrew M.F. Carr, who I met and who has been by my side steadfastly since this moment in 2007. So thank you so much. David, who will be setting up in the next 10 minutes. I haven't seen some of you in a very long time. That's grad school, so I'm actually going to head downstairs by the front door to say some hellos, and if you have any questions or want my card, that's where I'll be for a while. Thank you.